I want to start in Endo 2012, June 2012. We presented this study from Memorial, follow-up of suspicious lymph nodes that we showed that usually remain stable over follow-up. So during this presentation, you have 10 minutes for presentation and 5 minutes for questions. So 10 minutes go by, everything is okay, you take a deep breath, then the questions start. And then one quite famous endocrinologist goes to the microphone and says, this is wrong. If you're going to leave these lymph nodes in the neck, the patients will have distant metastasis, they'll have severe disease, and it's all because of you, because you left these lymph nodes. So I had like 1 or 2 minutes to say, well, that's not the natural history of the disease, that's not how the disease behaves. But ever since then, every time we treat less, I have this question in my mind, how do I know that bad things won't happen? So when we leave lymph nodes in the neck, we have questions. Will they grow? Will they cause local complications? That we can do within a couple of years. But what is the long-term impact of this approach? So first, let's start, why would this endocrinologist think that leaving 2 small lymph nodes in the neck, like this case, would cause such dramatic outcomes? And it goes to the traditional paradigm of the natural history of thyroid cancer. We can call it the old paradigm. So this paradigm says you have a small papillary thyroid carcinoma, then it goes bigger, then you have small lymph nodes, then you have more lymph nodes and more lymph nodes, and then you have distant metastasis. We can call it the stepwise progression paradigm. Now, according to this, if we treat the neck, if we take out the initial tumor and we treat aggressively the lymph nodes, take them all out, then the outcome will be better and we won't have distant metastasis. So we've become much better in doing this. We used to palpate the neck. We left a lot of disease behind. Then we had basic ultrasounds. Now we have extremely good ultrasounds. And with the years, we detected more, we treated more small recurrences. And the theory goes that better detection, you're going to treat these patients, you're going to have better outcome. Now, the problem with this paradigm is that it's wrong. Why is it wrong? Because it doesn't explain the behavior of the disease that we see in real life. And there are many arguments to say it's wrong. I just want to mention 2. So first, survival. Did we get any better in treating thyroid cancer? If we treat more, do the patients have less distant metastasis and better survival? So there are several studies. One of the best studies is online now. Ellen Ho and colleagues. They looked at the SEER database from 1973 to 2009. There you have general information, and they had the Memorial Sloan Kettering data, more than 2,000 patients, to have more detailed data. And the results were exactly the same. If you look per size, less than 1 centimeter, 1 to 4, or more than 4, the survival is completely the same all this time period. If you look per lymph nodes, if you have lymph nodes, you don't have lymph nodes, or per metastasis, along the years we detected more, we treated more, we made 0 difference. Now, they also mentioned that there's no difference in the occurrence of distant metastasis. So that really doesn't fit the stepwise theory. Now, a more substantial problem with the stepwise theory is that today we know that we find micrometastasis all the time. And how do we know that? We have studies that I'll mention that they took all their patients and did prophylactic central and lateral neck dissections for everyone. Prophylactic. They didn't have anything on ultrasound. So the first study was mentioned by WADA in 2003. They found only micropapillary, level 6 microcarcinomas. That means the pathology saw micrometastasis, 65%. That's a huge number. Lateral neck, 45%, and another study, 2008, central neck, 44%, lateral neck, 56%. And just recently, again, it's online, from the group in Pisa, the first randomized controlled trial on prophylactic central neck dissection. 181 patients, 5 years of follow-up. That's a good number and good follow-up. And the conclusion, almost 50% who had prophylactic neck dissection had micrometastasis, and it didn't matter. Prophylactic neck dissection didn't make a difference. And the last sentence in the conclusion, it seems that being aware to these lymph nodes doesn't make a difference. Now, it doesn't make sense. Where do these lymph nodes come from? Why are they there? And how come they don't make a difference? And obviously, it doesn't fit the stepwise theory. So we need a different theory to understand what's happening with what's the natural history of thyroid cancer. And this is one of the best reviews that I really like, Mike knows that, about the metastatic dormancy. And how we understand papillary thyroid cancer today, we can call it the dormancy theory or paradigm. Now, what does that mean? So first, there's early spread of cancer cells from the tumor. In papillary thyroid carcinoma, it's mostly to the lymphatic system, but this happens very early. Then, these small cancer cells go to specific organs. It can be by mechanical trapping or site-specific adhesion, like papillary thyroid carcinoma likes the lymph nodes. And then, once the thyroid cancer is there, they do not grow. They are dormant. And why is that? It appears that it's very difficult being a metastasis, because you don't have what you need to grow. You don't have blood vessels, you have the immune system attacking you, you don't have the fibroblasts that you need, you don't have all the things you need. So this is from a review in Nature, and this is true for most cancers that we know. It's not just papillary thyroid carcinoma. What's special about thyroid carcinoma is almost all micrometastases remain dormant for many years. So if you take them out, if you leave them behind, like prophylactic neck dissection, it doesn't matter because they remain dormant. Now, uncommonly, some of them lose dormancy and start to grow. It can be either the tumor itself, mutations, it can be changes in the microenvironment, or systemic factors like growth factors and things like that. And here's a very complicated diagram. You have the dormant micrometastasis. All of these things make it hard. They're alive, but barely alive. And then something happens. Something changes, and then it becomes metastasis that we can see that grows. And you can see it's not easy for metastasis to grow. They need to have survival and outgrowth, immune evasion. They need to harness the coagulation system. They need angiogenesis, vasculogenesis. It's not easy for the metastatic site to grow. Now, we understand from this concept that the target to treat thyroid cancer is not to treat the neck. The target is to understand these factors that make dormant metastasis active. And we have Dr. Cohen. This is the challenge because these dormant areas don't respond to chemotherapy and they keep popping out in all cancers, not just thyroid cancer. So now, with this theory, with this understanding, we can understand why we have no benefit from prophylactic neck dissection. We take out dormant metastasis. We understand why there's no long-term benefit from aggressive neck treatment. Like we saw in survival, there was no difference. And it also explains the low success rate, biochemical success rate, of repeated surgery, like Merav showed. You have these studies about repeated surgery. Biochemical remission is only 27 to 50%. Why is that? We took out the disease, but we left a lot of micrometastatic lymph nodes. We don't see they're there. They make a little thyroglobulin, but they're not clinically evident. Now, even though the benefit is not that good, we still have the complications. Again, Merav showed you, this is from the same reviews, nerve paralysis around 1% and hypoparathyroidism in the central neck around 3%. So we're not changing the overall behavior of the disease, and we do have a price to pay for going to surgery. So now comes in the study that we started with, the study in Memorial. Now Mike Tuttle and Ashok Shaha in Memorial for many years saw small recurrent lymph nodes and just followed them. And what we did, we went over 5,000 ultrasound reports, found all these small suspicious lymph nodes, and looked what happened during follow-up. So we had 166 patients. All of them didn't have aggressive features. If you have aggressive features, you'll be more likely to go to surgery. So no aggressive features. The median size, it's going to be confusing. Long axis, short axis. We looked at the long axis because we endocrinologists are used to looking at the long axis. And the follow-up was 1 to 13 years. The median was 3.5 years, but we have had quite a lot of patients with 9, 10, and more years of follow-up. And these are the results. The median number of ultrasounds was 6. So you see ultrasound after ultrasound after ultrasound. 80% had no change, 20% had minimal growth, and out of these 20%, 9% had growth of more than 5 millimeters. Eventually, 13% of patients went to surgery. That means we prevented surgery in more than 80% of cases, and these patients didn't have the complications that would come with surgery. Now, the other question that we had, would we have local complications? We leave disease behind. Will we have difficult surgery later or other problems? And we didn't find any local complications in 166 patients. That's a large cohort. So this was very reassuring. Now, again, why would you have a lymph node that grows to 6 millimeters? Why would it stop? It doesn't make sense. We say it was dormant, then it grew. Why would it stop? And that goes to, again, how difficult it is to be a metastasis. You need a lot of characteristics and abilities to grow more than 5, 10, 1 millimeter. And papillary thyroid carcinoma metastases are not that talented, and usually they grow some, but they usually stop, at least in the neck. Now we go back to our patient. He's 65-year-old, has 2 suspicious lymph nodes, 6 millimeter, 5 millimeter, and I discussed these theories and paradigms, but you have to make a decision. So you sit with this patient in the clinic, and you have to make the decision. And it's not easy because there are all these considerations for and against. So we need a guide, right? A guide to show us what to do. And Merav discussed it, but we have a decision-making guide. It's one of the papers she discussed. So what they have this huge table that tells us what favors observation and what favors surgery. So I want to show you only the most important thing in my mind for the decision. So size, and we're talking about the short axis here. If it's less than 1 centimeter or 8 millimeter, then favor observation. If it's larger, favor surgery. Rate of growth, this is already observation. You don't rush to surgery. If it's stable or slow growing, you can watch. If it's progressive, you go to surgery. Age of the patient, this is just the follow-up. If you have a young patient, just following these lymph nodes is going to be a lot of work. So younger patients are more likely to go to surgery, older patients for observation. Central neck, the surgery is more risky. So if the central neck, you hesitate before you go to surgery, and the initial tumor. If the initial tumor was more aggressive, you would be more likely to go to surgery. So back to our patient. Our patient had a small lymph node. He's an older patient. The lymph node in the lateral neck, so the surgery will be a little easier. And he didn't have aggressive features in his initial disease. But what we're missing is what's the behavior? Will it grow or not? So what we need to do now is follow the patient. And if the lymph nodes don't grow or grow very slowly, then we'll be here, and then we vote for observation. If we follow the patient and we see growth, then obviously we go to surgery, and this is a safe approach, as we showed. Now, again, guidelines, Merav mentioned it. Probably you will say probably, that lymph nodes smaller than 8 to 10 millimeters in short diameter can be followed and go to surgery only if you have growth or if they threaten vital structure. Now, short axis is extremely important. Look at this. This is a suspicious lymph node, obviously with microcalcifications, 1 centimeter over 4 millimeter, short axis 4 millimeter. This is for observation, and this is one of the lymph nodes from our study. We have 10 years of follow-up, and it remained completely stable. But we used to looking at the largest diameter. Now the convention goes to the short diameter. So in conclusion, we have new insights of how the disease behaves and what we should target, not the neck, but understand the biology and loss of dormancy. Small lymph nodes in low-risk patients tend to remain stable, so the active surveillance is preferred in many patients. It's not just an option, it's preferred in many patients, and as we can see, as we talked all through the day, we have to discuss it with the patient, see where they stand, and then make a decision together. Thank you.